Okay, so we are educating people in terms of the nature of the experience. And we know that the more we know about pain experience, the less it can hurt. So as soon as we start to demystify that and be that voice that says, oh yeah, this makes sense. I've seen this before. You've been through a heck of a lot. Yeah, this is very real. To have somebody that recognizes a chronic pain syndrome, what is chronic pain syndrome, and to deliver those messages is absolutely key. Before we move on, we have to think back to Maslow's hierarchy of needs. I had a patient this week who didn't have shelter or food coming her way. So if we're there, we need basically an immediate social work consult. We need to rope in, the resources that this patient needs to feel safe and be nourished and have her children nourished before we can start talking about anything else. So yeah, that's got to come first. I should mention, like Rosa did in her presentation, that we in the transitional pain service use ACT, acceptance and commitment therapy, which is kind of like your third wave cognitive behavioral therapy. We're the three of us trained in that. So constantly doing this dance between these different ideas. Contact with the present moment, radical acceptance of where we are, defusion, which is avoiding being hooked by hot thoughts, self as context. And then ultimately what we're all trying to do is to help patients live meaningful lives, like the lives that they would like to live. So most of these patients come in having a hell that they want to run away from, but then our role can be helping them build a vision of a heaven to run towards as well. And that's what ACT is ultimately about. It's about identifying values, making goals, and then breaking down the goals into bite-sized chunks and decreasing the barriers. So that is the background there. That is really meaningful. And this is also heavily based in mindfulness practice. I cannot move on without emphasizing the importance of physiotherapy. Prehabilitation is this process of setting somebody up from the perspective of just their physical fitness to present for surgery. When people are on surgical waiting lists, they often do just that. They wait because they are told you have a surgical problem, the surgeon will fix it. Now you must wait for 2 years, maybe more. So people become certainly deconditioned and they need guidance. They develop kinesiophobia and they develop, high sensitivity to pain. So we work a lot with physiotherapists, especially on decreasing that sensitivity. So that, and then occupational therapy, absolutely important role here. We need OT planning, detailed OT planning, and we need to have that conversation about work, the value of work. If our aim is to make these patients feel safe, if we believe of this, danger messages versus safety messages, then who feels safe if they can't earn a living, right? This is an essential piece to bring in early.